Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts.
Hi, welcome to the latest episode of the Liver Lounge podcast under the Liver Foundation. So I'm Dr. Margaret Teng. I'm a consultant from the National University Health System in Singapore. And I have here with me today Professor George Ioannou. He's the Director of Hepatology at the Veteran Affairs Hospital in Seattle. He's also Professor of Medicine at the University of Washington in Seattle. So welcome, Professor George, and thanks a lot for joining us today.
Thank you, Margaret. Nice to be here.
Yes, that's great to have you here. Professor George has recently released a book called Kintsugi Medicine in the Veterans Health Administration, and he's a very well-known figure in the world of hepatology. He's published extensively on various fields in hepatology, and he's had a extensive clinical experience in the Veterans Health Administration. So, Professor George, maybe I'll just start by asking you, what actually were some of the personal motivations, or what prompted you to write this book?
Yeah, thank you, Margaret. It was a difficult book to write, actually, because it summarized 15, 20 years of my experience working in the VA hospital in Seattle, taking care of patients, and also some personal health issues that I had. The book, like you said, is called Kintsugi Medicine, and it has three topics that are intertwined in the book. The first topic or concept is what I call Kintsugi Medicine, which is the idea that through their experience of illness, patients can actually acquire the opportunity to gain spiritual growth, to improve, to get deeper relationships with other persons, and that we shouldn't look at patients simply as broken and in need of fixing, but maybe acknowledge the possibility that through illness, there is the potential to acquire a certain wisdom and apply that to the rest of our lives. And that is a concept that runs across many philosophical and religious traditions. In other words, the idea that true wisdom comes through suffering. And if that's true, then many of our patients, especially the ones who suffer from chronic illnesses, probably have the capacity to acquire that wisdom. And if we're smart as doctors, we should look out for that and experience it ourselves through our patients, and maybe ideally even learn to promote that. I remember going through the entire medical school and through many, many years of education and training. And although we are always told, Margaret, right, to learn from our patients, right, to learn how to practice medicine by observing patients and their course through illness, taking their histories, following them through the wards, nobody ever told me to try to understand how they experience their suffering, right? How do they respond to it? And some people respond to it. It's always difficult, and I'm not saying doctors should always aim, first of all, to treat and alleviate the suffering, but many patients are able to cope with that. And I noticed that specifically in the VA hospitals, the veterans hospitals, many patients were able to cope with their suffering with tremendous grace and courage, and almost emerge stronger, and they had a deeper peace and courage and grace, like I said, which was really enviable. And I learned to observe that. And in the book, I describe a lot of vignettes that give examples of that. Now, where it all came to head, and you said, what was the motivation for writing the book, was that I myself then experienced a stroke when I was 34 years old, right after my gastroenterology fellowship. When I first became appointed as a staff physician, I sustained a dissection of my right vertebral artery, which resulted in a small stroke. So then the tables were reversed, and all of a sudden I was the patient, and I had to learn how to cope. and you know, the stroke was not devastating, but a stroke is a stroke, and it took me many years to get over it. And the experience of my patients, of my veteran patients, was a guiding light for me. It was their way of, I learned through them how to cope with illness, and their grace and their courage gave me motivation to proceed. And I think I hope that in the future we can look at patients in that way, as wise human beings, that their lived experience of illness has given them a wisdom that we can all learn from.
That's an excellent way of summarizing the book. I think thanks for sharing with us your personal story and also the stories from your long career. I think it sounds like we learn much from our patients, not just the medical problems, but also the way they encounter and they go through adversity with grace, as you mentioned. Now, maybe I'll just like to ask, in your career, what do you think are some of the greatest challenges you faced in treating veterans with liver disease?
Well, Margaret, if we go back, so like I said, I've been in medicine for a long time, and especially in the VA. I've had clinics in the same hospital since the year 2000, for 23 years. And for the first 15 years, let's say from 2000 to 2015, in the VA, and maybe a lot of the rest of the world, liver disease was dominated by hepatitis C, right? It was particularly an even bigger problem in the VA, to the point where around 2010, the VA had almost 180,000 patients infected with hepatitis C, a huge population. And that was a consequence of the well-known epidemiology of hepatitis C, which affected baby boomers in the United States in particular. That's persons born between 1945 and 65. And those are the people who served in Vietnam. And then when they returned from Vietnam, they became veterans. And so the VA had a very large population of hepatitis C. During those years, as you probably know, we did not have good treatments for hepatitis C. Treatments for hepatitis C were based on interferon. They were tremendously burdensome to take. They were long. You had to treat patients for a whole year. Huge amounts of side effects, and the response rates were very low. And so during those years, there was a feeling of great pessimism and almost despair among the patients, even among the doctors, because it was tiring to see patient after patient get cirrhosis and liver cancer and not be able to do anything about it. Only a tiny proportion of patients have been cured of Hep C. And then the greatest miracle that happened, I don't know where you were in your career, Margaret, in around 2014 or 2015, but when the direct-acting antivirals became available, it was absolutely unbelievable. Like, I mean, it was the happiest time in my career because we could treat hundreds and thousands of patients and eradicate the hepatitis C and transform their lives literally in a matter of weeks. And that was one of the greatest successes as well of the VA as a healthcare system. The VA jumped on that really quickly. Immediately, all direct-acting antiviral therapies became available in an unrestricted way across the VA. It was the first healthcare system that made all the direct-acting antivirals available, even back in 2014 when everywhere else they were being restricted because of costs. And within 3 or 4 years, the population of positive hepatitis C patients in the VA dropped from 180,000 to less than 30,000. It was absolutely transformative. Like within our hospital alone, we treated thousands of patients with hepatitis C and eradicated the hepatitis C. And you could see immediately like complications of cirrhosis, like portal hypertension, patients who had ascites, patients who had encephalopathy, getting better very quickly, and most of them not progressing at all. And we could even see reductions in the incidence of liver cancer. And those things we studied it was a great time because I could see those things in the clinics, but I was also studying those effects of viral eradication using national VA data. And we were some of the first groups to show the reductions in liver cancer risk, for example, after eradication of hepatitis C, reductions in incidence of ascites, of encephalopathy, of complications of portal hypertension. And we even showed at a national level for the first time a reduction in the incidence of liver cancer caused by hepatitis C in the VA as a whole. So for 20 years, ever since we had data, every single year, the incidence of liver cancer was going up and up and up and up from 2000 all the way to 2016 or 17. And for the first time after 2016 and 17, the liver cancer incidence declined. And that was directly the result of the eradication of hepatitis C a few years prior. So it was an amazing time and an amazing experience.
Okay, just a quick question about your experience in treating hepatitis C. As we know, the care cascade for hepatitis C, there are many steps, right? There needs to be screening, there needs to be linkage to tertiary care, and then there's testing and whether the patients are compliant. And I would suspect for some of the veterans, especially those, you mentioned that they have mental health illnesses and they would be, more likely to have alcohol use or substance use disorders. What would some of the real world or on the ground challenges that you face in terms of getting them to come back for treatment, to be compliant, and then to test after treatment? And also, I guess some of the challenges and what are some of the concrete steps or tips that you would give our listeners on how to overcome these challenges, especially for those from countries where hepatitis C may not be completely eradicated yet?
Yeah, well, you're right. The first step is screening. They used to call the hepatitis C the silent epidemic, and because it's true, patients are asymptomatic until they develop cirrhosis, and a lot of patients still do not know they have hepatitis C. So you're right. The first step in the cascade is screening. Screening is complicated because it has to happen at the population level, and each system, each country needs to figure out its own way to do it. So assuming you have screening and you have identified the patients, then again, you're right that for most of them, it's pretty straightforward. And you said, let's find them and link them to tertiary care. I think we have to be careful. I don't think treating hepatitis C is that complicated in this day and age. Yes, perhaps tertiary care, but you don't have to be a huge expert to administer an 8-week course of Harvoni or Mavired or what have you, right? For 8 weeks or 12 weeks to take pills, as long as somebody can tell you what the appropriate treatment course is, it's pretty easy, right? So if in places where the barrier is access to treatment experts or specialists, right, the solution might be to expand the providers who are knowledgeable and feel comfortable prescribing, right? And now the VA did a great job with that from the get-go. For example, mid-level, what we call mid-level providers, nurse practitioners, providers, physician's assistants actually do the vast majority of the treatment, and even what we call clinical pharmacy specialists. In most hospitals, they do the majority of the treatment. So expanding the number of providers is a great option. And then you mentioned those subpopulations that are particularly difficult still to treat, maybe because of compliance issues. Now, this used to be a huge problem, Margaret, back in the interferon era. I don't think it's such a big problem now, but you're right. You still have to be compliant and take your medications. There isn't that many side effects, but patients with active substance use disorder issues, patients with alcohol use issues, those patients should not be declined treatment, right? They should still be treated. The question is to make every effort for the treatment to be successful. And that's very important because with a lot of treatments for hepatitis C, you still get one chance, that chance that you get is your best chance to eradicate it, right? So the real question is, can you get a person to be compliant with 8 or 12 weeks of treatment, 56 or 72 days of taking a pill or pills every single day? Whatever you have to do. We use social workers a lot. We have a whole army of social workers who help us monitor patients, make sure they can make it to appointments if they need to make appointments, make sure they get their medications. We use mailing of medications, for patients who cannot come and get the medications in person. We use telephone appointments and telemedicine and monitoring by phone and video to ensure compliance. These are all things that we have been doing for so long that it's almost second nature. But the message I wanted to convey is, don't be afraid to treat patients with hepatitis C, expand the number of providers, and even the so-called difficult to treat populations are not so difficult to treat anymore.
Sounds like a great success story for the VA. But now that hepatitis C seems like more or less going to be completely eradicated or mostly treated in the US. In the past few years, what do you think are some of the more current challenges that you face, especially in these veterans with regards to liver disease in particular? Would it be
Margaret,
alcohol use? Yeah.
Our job is going to become more difficult now because all of a sudden all of us have to become experts at treating what used to be called non-alcoholic fatty liver disease, what's now called metabolic associated steatotic liver disease, or MASLD, and that's a much more difficult issue. I sometimes, Margaret, I almost long for the days when we could just treat hepatitis C and we knew what we were doing and it was nice and easy and we could cure. I don't think there is such a thing as cure for fatty liver disease. And so obviously in the VA and everywhere else in the world, it is no secret that the emerging disease that we're going to have to deal with in the next 10, 20, 30 years is MASLD. And it's a much harder proposition for a number of reasons. First, from the population perspective or the epidemiology perspective, screening and identifying those patients is not easy, right? Because we don't have a simple biomarker like you can test for hepatitis B, you can test for hepatitis C, and do you have it, yes or no? Well, for fatty liver disease, it's not that simple. There isn't a simple biomarker. People argue about what the threshold should be, about whether we're going to use the fibrosis 4 score, whether we're going to use something else, and at what level, at what threshold should, whether we should screen even everybody, whether we should screen patients with diabetes, whether we should screen patients with some risk factors, and then at what level of a threshold should that trigger referral to a liver clinic. So each system has to figure those processes and that cascade of care, like you mentioned earlier for hepatitis C, they have to translate that into fatty liver disease now, and it's much more complicated. I hear a lot about a lot of guidelines that are well-meaning, like they say everybody should have a fibrosis 4, or almost everybody should get a FibroScan, and it scares me because I know at the population level, if what they say is true, and then everybody gets a fibrosis 4 score, and if your fibrosis 4 score is greater than 1.6, get referred to hepatology, that means thousands and thousands of patients get referred to hepatology, and there's no way we can see them all. I mean, there's absolutely no way. So that's just the screening part. And then once they get to our clinics, the management is much more complicated, right? The cornerstone is still lifestyle, diet, exercise, improvement in nutrition, ideally weight loss. And then there's a whole cadre of pharmacotherapies that are not yet FDA approved, but are very promising. There's bariatric surgery. And then there is management of all the associated risk factors that go with fatty liver disease that are just as important, if not more important, the diabetes, the hypercholesterolemia, and so on and so forth. So life is very complicated for a hepatologist in the next 10 years, I think.
Indeed, I think this is something that all of us feel, that the epidemic now moves more to MESO, metabolic associated steatotic liver disease. Now that viral hepatitis, even viral hepatitis B, I think they're moving towards cure, and there's very good viral suppression, virological nucleotide analogs or nucleoside analogs, which have great virological suppression. So I think the next great challenge on the frontier would be MESO, as you mentioned. Now, maybe we will change tracks a bit and talk about, something you mentioned earlier in this interview, and also the main theme of your book, which is Kintsugi Medicine. Theoretically, it sounds like a very good concept, and I think that it's something that is really worthwhile exploring, especially as you mentioned earlier in our careers or in medical schools, where I think physicians need to start thinking of the patients as individuals and how these can, help us to empathize more for the patients and improve our relationships with them. What are some, concrete or more tangible ways that you would kind of recommend for in educating physicians or even students about this concept, and how would you introduce this concept to them and teach them how to practice this?
Yeah, those are tough questions, Margaret. I don't know that it's something that I could teach. It's something I'm trying to experience myself. I will tell you some lessons I've learned. One important lesson is, obviously you can only even begin to understand how a patient experiences their illness if you have a prolonged relationship with them. It's not something that you can gather in a 30-minute appointment one time when you see a patient. And I think that's something that might be missing in some of our education, especially medical school residency, where physicians rotate from clinic to clinic, from rotation to rotation. And that's something that's missing. There's definitely needs to be at least one continuity of care clinic where training, doctors in training and junior doctors can get that long-term relationship with a patient, because that's not something you can understand in quick appointments. So assuming you have that long-term relationship, and I've been very lucky with that, because my relationships go 20 years, 10 years, 15 years. And so I was blessed by that. But I know that not every healthcare system, not everybody's going to have that, but at least get 1 year, 2 years of some kind of continuity. Now, during that time, I think it's important for us to observe how patients cope with the suffering of their illness, and how some of them, then you begin experiencing that some of them are able to draw strength. Some of them are able to form closer relationships with others, even with you as their doctor. You can tell that they seek it, and they become more empathetic. I think part of they turn their vulnerability into empathy. And now, so I suggest that we just begin by start observing that. Now, not everybody is able to do that. And I'm not saying I was able to do that. I'm just saying I observed a lot of patients who were able to do that, and who were able to grow spiritually as human beings through their experience of illness. And so begin by observing that. You will notice some people, some human beings, some patients who are able to accomplish that, and some are not. Now, the next step, I think what you were alluding to, is, can you learn that and can you teach it? That's a really big question. That's a really big step. Can you can you teach a patient how to derive Kintsugi medicine, or what some psychologists are calling post-traumatic growth? That's another kind of more formal term. I use the metaphor of Kintsugi medicine because I like the Japanese art of Kintsugi, which is, you take a broken pot, you fix it with golden lacquer, and then it becomes a more beautiful object, and the fractures and the imperfections of the broken pot actually contribute to the beauty and the value of the object. And I like that metaphor. But more traditionally, that's called post-traumatic growth. I think it's controversial whether we know how to promote post-traumatic growth, that we can that we have ways to facilitate that in patients, that we can try to encourage or coax it, or make it more likely that a patient will have actually a growth experience out of their illness. I wish I could tell you that there was a way to make that happen, but it's very complicated. Now, the other thing I wanted to make it absolutely clear, Margaret, is that suffering is still a terrible thing, and doctors should aim first and foremost to alleviate it. And we should never consider patients who suffer as somehow being on this pathway to self-discovery and growth and spirituality. That would be almost cruel to suggest that. All I'm saying is that at the same time as trying to alleviate the suffering, recognize the value of that lived experience in the patient. Don't treat them as just a broken person, somebody who is less than because they're sick, but recognize the value in that lived experience, the value in that wisdom that they might have acquired, the value in that spirituality. And maybe as physicians, learn from it, because one day you may be on the receiving end, and you might have to deal with illness as well.
So that's, I think, is a great kind of conclusion to this interview. I think thanks a lot for spending the time to talk to us about your book, and also sharing with us some of the, your experience in clinical medicine in the VA, as well as telling us about this concept of Kintsugi medicine, and maybe sharing with us not just your story also, but your patient's stories via your book. Is there any other last words that you'd like to tell us before we close this interview, or is there anything else?
No, Margaret, thank you. I wanted to say one more time, I feel blessed that I had this opportunity to work both as a doctor and specifically in the VA healthcare system, and to benefit both from my colleagues and academically, and more importantly, from my patients personally, to benefit from them in my recovery from my own illness.
And I think likewise, your patients and also the other hepatologists around the world have also benefited much from your expertise and your sharing. So thanks, Prof. George, and thanks to everyone who's listening in to this podcast, and please tune in for our next episode as well. Thank you and goodbye.
We have come to the end of the episode. Thank you for joining us, and stay tuned for more captivating discussions.